Welcome. I have the pleasure of introducing this session, which deals with advances in heart failure management. In particular, we will focus on a new method and a new technique and a new equipment for pacing the left ventricle. And later, we will review digital health in the relation to current patient management. So I'd like to introduce the first speaker, Professor Frédéric Anselme from Rouen University Hospital in France, who will talk to us about the AXONE LEAD project, a new way to navigate the left ventricle.
Good morning, everyone. I'm Dr. Frédéric Anselme from Rouen University Hospital in France. I'm going to talk about the AXONE LEAD project, which is a new way to navigate the left ventricle. The AXONE technology is an emerging new technology consisting of an ultra-thin quadruple LV lead, which is able to navigate through collaterals between veins and very thin veins. The lead is very thin. It's 0.4 millimeter or 1.2 French in diameter, as you can appreciate on the left-hand side of the screen. Due to this very thin profile, we cannot navigate with the lead itself. It has to be delivered with a microcatheter. As you can see on the video here, we have first to introduce the guide wire in the position where we want to deliver the lead. Here, for example, the microcatheter is delivered through the anterolateral vein, cross a collateral to the mid-cardiac vein. Once the guide wire is advanced, then we introduce over the guide wire a microcatheter up to the end of the guide wire. Then the guide wire is removed and we introduce the AXONE LV within the microcatheter up to the end of this microcatheter. And once in place, we withdraw the microcatheter in order to uncover the microelectrode of the lead. The microcatheter is left in place and connected to the lead itself, and the whole system is connected to the box. We have tested this new technology in a preclinical setting in 7 healthy adult dogs. The lead was chronically implanted for 3 months, and the follow-up was performed at 1, 15, 30, and 90 days after the implantation. We could implant this micro lead in all dogs with success, and in 5 out of 7 dogs, we put the lead across collaterals, as it is shown in the several pictures that you can see on the screen. Here, there is an example of a cross vein placement where the lead is positioned through the anterior great vein, cross the collaterals at the apex of the left ventricle, and go towards the mid-cardiac vein. The lead position was checked via fluoroscopy at each follow-up. It was stable in all cases. At microscopical evaluation, 3 months after implantation, there was an excellent local tissue tolerance of the lead. Here are the preclinical evaluation in terms of electrical parameters. And as you can appreciate, there was a stable electrical performance under chronic conditions. As you can see, the impedance was pretty high as compared to what we observed with a conventional LV lead. It was 2 to 3 times the value of a conventional LV lead. At 90 days post-implantation, the pacing energy was always less than 2 microjoule. And as an example, 2 microjoules is what is delivered at 1.4 volts at a pacing impedance of 500 ohms for 0.5 milliseconds in pulse width. As you can see here, there was a slight increase in pacing threshold and a return almost to the baseline value. We also performed an acute clinical study based upon the pretty encouraging result of the preclinical study. And I'm going to show you two cases in which we have delivered the lead and then removed the lead for implantation of a standard LV lead in CRT-indicated patients. You have here the angiograms in RAO view, and you can see for this first example that we have used the lateral vein to introduce the microlead. And you have here on the bottom of the screen the position of the lead in place whilst implanted. This was a 68-year-old female with ischemic cardiomyopathy and a LBBB on ECG with a low ejection fraction. And the AXONE lead was implanted, as I said, towards the lateral to the posterior vein. The pacing threshold was pretty good in this case, and which enabled bi-zone pacing between LV1 and LV4 at a very low pacing threshold. In this second case, again in RAO view, you can appreciate at first glance that the venous coronary anatomy is pretty thin and tortuous. We could, however, implanted this microlead in a cross vein position towards the lateral vein and the mid-cardiac vein again. The pacing threshold was not so good as compared to the previous example, but still acceptable. But in this case, we could not introduce and definitely implanted a standard LV lead due to the very tortuous venous anatomy, and the patient underwent a surgical implantation for LV pacing. Based on these acute results, we have already started a chronic study that is a pivotal single-arm multi-center international trial which aims to assess chronic safety and performance of the AXONE lead. We intend to implant 152 patients at 20 sites in Europe. There are two co-primary endpoints. One, freedom from AXONE system-related complications at 6 months. And second, success of LV pacing at 6 months, defined as a pacing threshold below 3.5 volt for 1 milliseconds in pulse duration. There are also ancillary endpoints such as bi-zone pacing capability or acute effect of bi-zone pacing on electrical parameter and echo parameter, and of course the CRT response clinically and on echocardiography. The first patient was implanted on December 3rd at the Rouen University Hospital, and the study inclusions are in progress. In summary, the AXONE ultra-thin LV lead guided by the microcatheter is able to navigate through the thin coronary veins of the left ventricle. It is also able to pass through collaterals for cross-vein placement in 2 different zones, thus offering new options for pacing and CRT delivery. One, it's able to reach new pacing sites not accessible with current technology. Second, to select or change pacing sites to better optimize CRT secondarily to implantation if needed. And last, to perform true multi-zone pacing with a single lead with the optimal goal to improve CRT response. This ultra-thin lead technology is currently under clinical evaluation in the ASTRAL clinical study. I thank you for your attention.
Thank you, Frederick, for this very nice presentation and this very exciting project. Could I just remind the audience to submit questions to the Pigeonhole, and the passcode is 339146. We'll go straight on to the next session by Professor Martin Cowie, who will talk to us about digital health and how it can contribute to current heart failure management. Thank you.
Thank you very much for the invitation to talk about the exciting topic of digital health and what it's bringing to heart failure patient management. My name is Martin Cowie. I'm Professor of Cardiology at Imperial College in London, and I chair the Digital Health Committee of the European Society of Cardiology. So it's a very exciting time for cardiologists and digital health. And you'll all be very aware that the past year of the COVID pandemic has accelerated the adoption of many different digital technologies. In fact, there's a term for it. It's called the tech acceleration. Been a lot of investment in this, and almost overnight, many of us had to change to a remote way of consulting and also monitoring our patients. There's also been a huge amount of development in apps and wearables, which I'll talk about very briefly, and interest in using machine learning to supplement human intelligence to arrive at better decision making. So a lot of changes happened very quickly in the past year. You'll all be familiar with these key aspects of digital health: remote consultation, which many of us are doing now routinely, and remote monitoring, which is a different concept. It's where you collect physiological information, symptom information remotely from the patient living at home, and use that information to help make better decisions about monitoring and about therapy, hopefully improving the outcome for patients, but also more convenient for them so they don't have to travel to see you. This is a rapidly expanding area, so there are many different wearable technologies. In fact, there's an overwhelming amount that you could actually wear that could give you physiologically interesting information. And I've put two recent reviews of this on the slide there if you'd like to read more about it. But it's not really a shortage of sensors or the technical capacity to do these things. It's about integrating the data into the workflow and making it manageable for the healthcare team to advise patients remotely using the data. And I think the vision is that we'll end up with a digital fingerprint for each of our patients. It will be many aspects of their physiology. So here it could be their cardiac rhythm, it could be their quality of life, and it could be their exercise capacity, their sleep quality. And of course, many of our heart failure patients have comorbidities such as diabetes. And in theory, at least, with the Internet of Things, all of these things can link together and be used to help support people in their long-term health conditions. But I think a very important point is, yes, the sensors are really important and they have to be accurate and reliable, and they have to be able to telemeter data back to some system that you can use to inform decision making. But it's also about those systems of sense making of these data streams and not being overwhelmed with more and more data, and the challenge of extracting the signal from the potential noise. And ultimately, it's about making better decisions, not just more decisions, that improve the outcome or experience of care for our patients. And that's the challenge of converting the exciting bioengineering and digital innovation into a meaningful difference. But even 10 years ago in the New England Journal of Medicine, opinion leaders in heart failure were talking about this concept of where you use technology to support people living with heart failure to adjust their therapy themselves and keep themselves much more stable. And you only involve the healthcare team when it's absolutely necessary, when things are not working in that closed loop system. Now, we're some way from this, but we are moving very quickly towards a more intelligent way of supporting people living with complex conditions. So just to give you a flavor of how the field has developed over the last 20 years or so in remote monitoring of heart failure, a whole range of different technologies, some of them very simple and standalone, others taking advantage of the huge amount of information you can get from implantables like CRT or ICD, and then also technology that's purely implanted for monitoring purposes, such as pulmonary artery pressure monitor. It's important to remember, though, and I hope I'm not coming across just as wildly enthusiastic without some realism, that when you put this into practice, it can have effects that you didn't predict. So here's a study, .hf, we published in Circulation 10 years, in fact longer ago. And you can see that we actually increased heart failure hospitalization with monitoring intrathoracic impedance. If you look at panel C, an 80% increase in hospitalization right from the get-go. And this was because all of the energies were directed to just one parameter. There was an alarm that went off in the device that often led to anxiety for the patient and the family. They would pitch up at the emergency room, and the team there would just admit them. They couldn't see anything that was terribly wrong, but because of that high background level of anxiety and concern about things, they were hospitalized. These were short. Nobody died during these hospitalizations. So you can see that data, extra data, can push things in the wrong direction. It also can be challenging to identify the signal from the noise. Here's the world's largest study of remote monitoring, REMHF, John Morgan and myself ran in England with 9 centers, 1,650 patients followed up for an average of almost 3 years. We couldn't identify any signal of improved outcome for the patients compared to very good usual care at those heart failure units. So it is possible to add a lot of extra workload, but the challenge is to make sure that that extra workload translates into better benefit. And this is where I think a lot of new approaches, better algorithms, the use of machine learning as well as humans to pick up signal from noise is making progress. We can identify higher risk patients, but even then, those high risk groups are not really that high risk, so many of them will restabilize. You can see the HeartLogic algorithm being developed at the moment, the FDA saying to a technology company, we like the algorithm, we like the way you've developed it, but you have to go out and do a randomized trial to show us that when you hand it to heart teams, it does improve the outcome. And I think that's quite right. We do need evidence before we adopt new things. And the key thing for me is that we have to move away from risk prediction to risk reduction, so that we can identify when we should intervene, how we should intervene, and how we can improve things for our patient. One such system, of course, is the pulmonary artery pressure monitoring. And yes, this is remote monitoring, but it's probably also the fact that it's a new therapeutic target. So you treat your patients differently than you would do without this information. And with better use of diuretics, more decongestion appropriately of your patients, you reduce the risk of heart failure hospitalization very meaningfully. So I think we are moving towards a kind of closed loop system for people living with heart failure. In the center there, MicroPort are also developing a system that connects their implantable technologies with an app and a weighing scale to try and improve the stability of the patients, to use more information and to get them more activated and engaged in disease management. And perhaps we're moving towards a situation that type 1 diabetes is finding itself, at least in wealthy countries, with continuous glucose monitoring, insulin pumps, and very tight control in a closed loop system. The ESC is very enthusiastic about getting engaged in this agenda, getting involved with the technology companies, the regulators, reimbursement, and real life to try and move things forward. We've got a new journal, the European Heart Journal Digital Health, and we also have annual digital health meetings. So please look out for those activities. Thank you very much indeed.
Thank you, Martin, for an excellent presentation. Can I just remind the audience to send in the questions to the Pigeonhole on passcode 339146. So I have 2 questions so far. For one for a couple to Frederick. One of the questions is from Dr. Heckman, who asks, how do you determine how to program your AXONE patient? Do you program unipolar LV CAN or standard bipolar, and which electrodes do you choose?
Thank you, Paco, for these questions. It depends really on where the AXONE is positioned within the coronary venous system. And we choose basically the pole to pace, from where to pace, looking at the position, the anatomical position of the lead, but also, of course, we look at the pacing threshold, the absence of phrenic nerve stimulation, and so on, like we do with a usual, regular, conventional LV lead. And we can pace in bipolar mode or in unipolar mode from the RV coil to the pole that you have chosen, or in bipolar mode. In fact, you may choose whatever you want.
Okay. Further question is from Dr. Albatat. How often can bizone pacing be achieved by AXONE, and do all patients have viable interconnecting veins?
So I'm going to start with the last point. Roughly, approximately 80 to 90% of the patients have connections between veins. We've demonstrated that in a previous study, looking at the anatomical relationship between the veins, and we found that we were able to travel from one vein to another through these collaterals in such a high percentage of cases. And the first part of the question was, again, I don't remember. What was it already?
So the other question was, excuse me, do all patients have viable interconnecting veins?
So in order to do dual pacing, we have to ensure that in both places the pacing threshold is acceptable. So and dual pacing is also defined as two pacing sites that are acceptably away one from the other. So basically it's around 7 centimeters or 6 to 7 centimeters. And that can be done in routine practice in around 50% of the case. So far, we don't have a lot of experience with that because we are going to start the chronic study with the ASTRAL study. So we don't have a precise number to be exact in this answer.
If I may ask, Frederick, there is some evidence, limited however, but nevertheless suggestive, that simultaneous multi-point pacing may be beneficial in some patients. And there are some very small studies, but nevertheless quite convincing studies to show that. Do you have a handle as to whether simultaneous biventricular pacing throughout all the different poles in this lead might be preferable to single site?
So far, we checked the left ejection interval, the LPAE, to evaluate whether simultaneous dual LV pacing could be better than single site LV pacing. And the data are not always in line with the fact that dual LV pacing is better than single LV pacing. So I cannot say for sure that dual LV pacing is better than a single site LV pacing.
Sure.
We need further data, of course, to better evaluate that point. But today we cannot say that.
Sure. That's very kind. Thank you. I'd like to turn to Professor Cowie. Martin, one of the questions is, would we expect or should we expect patient engagement to be a driver for better heart failure management, particularly with respect to availability of digital techniques?
Yes, I think in theory that's absolutely true, and there are some patients since the beginning of time that have driven change in particular conditions, and they're very politically active and high expectations. The problem, I think, is that many people, by the time they develop heart failure in their 70s or 80s, are rather fatigued, rather worn down by things, have lots of responsibilities, and actually the last thing they want to do is engage in trying to drive things forward. So quite challenging in heart failure, but we have wonderful patient advocates. And I think to the point of the question, I think consumerism and the choice and being able to shop around is something that digital does enable much more than traditional
just coming to a hospital to see the only doctor that's interested in your condition in your area. So that globalization is changing things, and people's expectations are higher. But it's very different from one condition to another.
I wonder, Martin, we've had many debates in the past, and you've done a lot of work on this to scrutinize really how valuable digital health may be. COVID, however, appears to have changed everything, because now a lot of those debates, in a way, are not as relevant, simply because we cannot see patients, or we haven't been able to see patients. In my center, we've increased telemonitoring from about 10% to over 95% in a very short period of time. And this is the lifeline we had. Do you think that the whole perspective of telemonitoring has changed as a result?
I think so. There's never let a good crisis go to waste, in a way. And overnight, people had to change what they did. And when they see the need, they do it. So like you, in my hospital, I was one of the few people that were interested in doing that, but everybody thought it was rather peculiar. Why were you doing this? And then with COVID, now everybody is an expert in remote consultation, and they like remote monitoring and can see the point. So it just shows you things can change very quickly in response to an external stress. What I hope, though, is that we don't go back to the old ways when the pandemic settles down. I think we should end up with being able to offer a range of things for our patients. Some of it might be completely remote. Others are kind of blended approach depending on what's needed. And then some face-to-face where it's appropriate. Personally, I find it useful if you've never met a patient to meet them face-to-face, so you develop rapport and trust, which is difficult remotely. And then also sometimes in a complex, multi-morbid elderly patient, you do need to examine them and see what's going on. So I think it's not one or the other. It's going to be a blend, I hope, once we come out of the pandemic.
I mean, one of the problems that we see, and which you demonstrated in your very nice trial, was the number of false positives, the number of alerts that you get from this. Do you think that AI may have some sort of role in filtering all of this noise?
I think so. I think in theory, but it's very important that viewers realize that AI is not magic. It's not like fairy dust that you just sprinkle over a problem and it disappears. It's just another way of trying to get sense out of data, to find patterns, to predict things for the future. It's hugely dependent on the quality of the data. But I do believe, in theory at least, that we will improve on risk stratification. I think, of course, in heart failure, there's many things that can cause decompensation. So it's probably not 100% predictable in any case, but we can improve it. But to your point, clinical teams do not like false positives. They feel they're doing a lot of extra work and it's not for any return. So very quickly, the human factors stop the chain of signal to reaction. So you have to be really careful about how you introduce this and support this and manage expectations that maybe the patient isn't that high risk, but you may have to assess them. And that kind of risk stratification triage system, I think AI and machine learning will help us with, but it won't be a magic solution.
And do you, in your routine clinical practice, use device data and other digital data?
Yeah, no, absolutely. And I like patient activity, which you get from the implantable devices. It's a very good marker of how well the patient's doing. Nocturnal heart rate is also a very good marker of sympathetic activation. And then atrial fibrillation episodes, as you know, it can be very important for particular individuals. So yes, I like to have that on the screen at the same time as the blood results, at the same time as seeing the patient remotely, all of the information together. And the technologists, the heart failure nurses, the physicians working together to help with the flow of data. So yeah, absolutely. I demand to be able to see the data.
Sure. If I may go back to Frederick, one more question is relating to the extraction. Do you have any experience on this?
Of course not, because we have just started to implant the lead, so we didn't get the chance to explain the lead so far. And to have a good idea of the extraction capabilities, we have to wait a little while, I believe.
So I don't have any experience except on animal studies where we could explant this lead very easily at 1 year, but still it's a pretty short period of time.
Sure. Well, I'm just wrapping up. I'm very grateful to Professor Cowie and Professor Anselme for these very nice presentations, and these are very exciting issues, which I'm sure the audience will share. I'm also grateful to Microport for sponsoring this session. Thank you.